Is there a role for immunotherapy in patients with metastatic colorectal cancer who have microsatellite stability? We know that patients with microsatellite instability derive an excellent benefit, protracted progression-free survival, major improvements in overall survival when we use immunotherapy in those patients. However, microsatellite stable colon cancer, which constitutes about 95% of our patients with metastatic disease, has been a very, 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 very tough patient population to help with immunotherapy. They do not respond well to immunotherapy. And there have been many studies that have evaluated PD-1 targeting alone, such as nivolumab or atezolizumab with PD-L1 targeting, and have failed to show benefit in that population. Recently, the Canadian CO26 trial has evaluated a different approach in combining both a PD-L1 inhibitor, durvalumab, with a CTLA-4 inhibitor, tremelimumab, in hopes of having a combination immunotherapy approach as an effective approach in targeting patients with microsatellite stability. This is an important study because it's a relatively large study. It's 180 patients. But you have to note that this was actually a randomized phase 2 trial. It was a 2-to-1 randomized study where 2/3 of the patients would receive combination immunotherapy and 1/3 best supportive care. And the study was designed with a 10% possible error. The study showed an improvement in overall survival of 2.5 months in favor of immunotherapy, saying that the p-value there was 0.07, which is less than the 10% error, with the p-value set at 0.1. So technically, it's a positive study. But it's a positive phase 2 trial where there were practically no responses, and there was no improvement in progression-free survival. It was somewhat surprising that we've seen patients without an improvement in progression-free survival, but yet derive a benefit in overall survival of 2.5 months. Still, these patients didn't fare extremely well, and the median overall survival was still in the range of 6 months with the combination immunotherapy. So is this enough evidence to use combination immunotherapy in microsatellite stability? No. Does this provide me hope that there are potential ways of accentuating further the benefits of checkpoint inhibitors in the future by looking at different combinations? Yes. So I think the Canadian trial is a landmark trial as far as giving us hope that immunotherapy should still have potentially a role in microsatellite stability, but certainly not enough to implement it in standard practice at this time.
So one of the combinations of interest is the regorafenib and nivolumab study. This was based on a study that came out of Japan looking at a series of colorectal cancer patients treated with this combination. These were refractory, almost all MSS, microsatellite stable patients. And when the combination was given, a response rate of 30% or slightly more was seen in colorectal cancer and in gastric cancer as well. This is a striking finding. Many of these appeared to be durable responders, and there's been interest in really trying to replicate that moving forward in future studies. We'll need to see those results before we're ready to act on those, but there are a number of phase 2 studies with this concept that are ongoing, and a randomized phase 3 that may be launching soon as well.
The question of what does the addition of PD-1, PD-L1 antibody to chemotherapy, potentially with an EGF receptor antibody, contribute in MSS colorectal cancer patient is, of course, of interest. We have very limited data suggesting that MSS colorectal cancer can be immunogenic at all. All attempts so far have actually failed to show that MSS colorectal cancer would respond to immunotherapy alone. There are data from the Module study, which looked at a combination of bevacizumab, 5-FU, and atezolizumab in a maintenance therapy setting. No signal at all. Now, using a combination of avelumab, cetuximab, and FOLFOX up front was interrogated in a German study of about 40 patients, and they showed response rates which are on the high end of what we normally see, 75 to 80%. But the question is, what is really contributing to the response rate here? What's the active component of the treatment when you have a doublet chemotherapy and cetuximab in a RAS-selected patient population? I'm not quite sure that we really understand whether avelumab, the addition of avelumab to the other agents, really made a difference in this study.